Hello, this is a brief presentation on the introduction to the neurological exam. In additional videos to come, I will be presenting each section of the neurological exam in more detail, but this is a brief introduction to each part of the neurological exam. So just a brief overview. Things that I always like to mention that it's important to do the neurological exam in the same steps each time you do it. That helps you to prevent forgetting to do parts of the neuro exam and to make sure that you are doing a comprehensive exam. So we'll go through each of these individually. So I usually start with mental status, and this is one of the first things that we test on our neurological exam. So first thing to assess is the patient's alertness, and this is things such as, are the patient's eyes open when you walk into the room, or do the patients not even open their eyes when you do a sternal rub or give them noxious stimuli? These are important things to note, and this can help you with considering the rest of your exam and the mental status. Also, do they keep their eyes open? Do they stay awake, or do they fall asleep very easily? These are other things to consider when you're doing the exam. The next thing I like to mention is orientation. It's important to avoid just writing in your notes AAO times 3 or in your presentations as well, because it can be very vague. It's usually what I like to do is to mention exactly what you asked and what the patient told you. So you could say, patient able to state their name. You also like to ask them if they know where they are. They can also go further and say, do you know what department you're in or what floor or building you're in? And then you can ask them things like the date, the time, and the day of the week. And then you can also ask them things like situation. So are they oriented to why they're in the hospital or why they're visiting you in the physician's office? The next thing I also like to mention, and sometimes cooperation can play a component in the neurological exam. So if patients are not cooperative, I usually mention it here as part of the mental status exam. The next thing we like to test is for attention. The way we do this is for serial sevens, or say spelling the word world backwards, or doing like things like months of the year backwards. Now, some patients with more profound encephalopathies won't be able to do this, so other ways you can test it are more simpler, such as counting from 20 to 1. And if they make any mistakes, this is often a deficit in attention, and frequently we see this in patients with delirium. The next part is the language exam, which is a very long exam in itself, but it contains multiple components, including fluency. Basically, do the patients make hesitations when they speak, or is it very fluent and smooth? Prosody, which is the rhythmicity of the speech. Repetition, so have them repeat a sentence such as, the spy fled to Greece, or into winter, the president lives in Washington. Naming, use both high frequency and low frequency words, so start with things like finger or pen, and then move to things such as watch, face, or watch band, things like that that are a little bit more difficult. Memory, so memory, I usually actually do this a little bit earlier in the exam, probably around when I'm testing for orientation. I will give them 3 words, usually things like apple, table, penny, it's a good option, and then ask them to repeat it back to me immediately, and that is considered registration. If they have any difficulties with that, that's considered to be likely a frontal lobe dysfunction, and then the later, about 5 minutes after we ask them to recall, you first see if they can recall them spontaneously, and then if they can't, then you move on to giving them hints, and if they can't do that, you do multiple choice. So this is all things that you mention when you're presenting or in your notes and documenting. And then you test funded knowledge. We ask things like who were the president, or who were the presidents, prior presidents, and then we also ask other current events that can help us assess for their overall fund of knowledge. And then we like to test calculation. Frequently, we test things like how many quarters are $1.75. This is a good test of dominant parietal lobe function, and that's where you can see some dysfunction here if there is involvement of the dominant parietal lobe. Next, we move on to the cranial nerve part of the exam. So, unfortunately, cranial nerve 1 is often not tested, but it really should be. It should be part of your standard exam, and you're testing for things such as smell of things like cinnamon or cloves are frequently used. And this is important, especially in early diagnosis of neurodegenerative diseases, especially Parkinson's disease. And then we test the second nerve, which is the optic nerve. So we start with visual acuity. You can start by testing visual acuity using the cards, but if their vision is poor, you may have to use things like finger counting or hand waving, or if it's even more poor, you can do light perception. And then we usually test visual fields, so test each eye individually. and then also do the pupillary reflex, which also, of course, involves cranial nerve 3. Now, cranial nerve 3 we assess through eye movements, and this, of course, will test cranial nerves 4 and 6. I'll talk a little bit more about them when we have a figure on the next page. You also look at the pupillary response and look for any ptosis. Now, cranial nerve 3 palsy usually has complete ptosis, whereas an incomplete ptosis is usually more suggestive of a Horner syndrome. And of course, each one, Horner's and oculomotor palsies, will have their own accompanying symptoms as well. So for eye movements, important. This is a good, helpful figure. This is looking at the patient. This is the right eye. This is the left eye. Here's the nose in the middle. And it's important to know what muscle and what nerve you're testing. So when the patient is abducting their eye, they're using the lateral rectus. When they look upward, they're using the superior rectus while their eye is abducted. If they look down while abducted, they're using their inferior oblique. Now, if they're adducting their eye, they're using the medial rectus. And if while adducted, they look up, they're using the inferior oblique. If they look down, they're using their superior oblique. So this is a helpful diagram to help remember what muscle is involved. And the mnemonic is LR6 and SO4. So superior oblique is controlled by the fourth nerve, and the sixth nerve controls the lateral rectus. All the other ones are cranial nerve 3. So moving on with the other cranial nerves, we then usually test the trigeminal nerve. So you check sensation in all the distributions, and then also test masseter strength, have them bite down and feel for their masseters. Next is the facial nerve, so you have them smile, puff out their cheeks, close their eyes real tight, raise their eyebrows, and this can help differentiate between involving the upper face or just involving the lower face. And then it's also important to test taste as well. It's because a true Bell's palsy should involve the taste function as well. Next is the eighth cranial nerve, and we usually test it with finger rub. And then in patients who are in comas, and we'll talk about a coma exam in an additional episode, but you check the vestibulocular reflex, which it also tests cranial nerve 8. Now, usually we test 9 and 10 together, the glossopharyngeal nerve and the vagus nerve, and that's things like dysarthria, palate raise, gag reflex. These are all things that we like to function. We don't tend to check gag reflex on awake patients, but especially for patients in comatose, we check for cough and gag. The 11th nerve is the spinal nerve, and we test for trapezius strength and sternocleidomastoid strength. Now, it's also helpful just to have the patient raise their shoulders multiple times and look for any asymmetry, which may be a more subtle sign of weakness in the trapezius. Then we check hypoglossal nerve, the 12th nerve. You stick out their tongue, move it side to side. Next, we move on to the motor exam. First, you look at appearance. You want to note any atrophy of the muscles, any fasciculations that you may observe, or any abnormal movements like a tremor or a chorea. Then you check tone. You check it both in the arms and the legs, and note any asymmetry or any increase or decrease in tone. And then you want to check strength. Actually, before I go to the formal confrontation exam, I usually check for subtle signs of weakness, and this is things like pronator drift, where you have the patient raise their arm up with their palms facing the ceiling, close their eyes, and look for any pronation and drift downwards. The other thing you can see is orbiting, where you have them basically bring their arms around each other, and if one arm is going around the other, that's a suggestion of one of the weaker arms. And then finger taps, you look for any asymmetry or also decrement, which you can see with Parkinson's or Parkinson's-like conditions. And then you do the confrontation exam. So it's important to know what 0 through 5 means. So 0 means no movement at all. 1 means you can feel or see the muscle contracting, but there's no movement along the actual joint. 2 is there is movement along the joint, but there's no movement against gravity. 3 is movement against gravity. And then 4 is split up into 4 minus, 4, and 4 plus, depending on how much they can withstand against resistance. And then 5 out of 5 is full strength. Now note there's no 3 plus 3 minus, 2 plus 2 minus, so make sure you don't mention that. Reflexes are usually the next part of the exam, and we usually score them from 0 being no reflex, 1 plus being a trace reflex, 2 plus normal, 3 plus is brisk, and 4 plus is clonus. And then we check for things such as spread and the Babinski, and then we also check for the Hoffman reflex. Now, This figure here shows the Babinski reflex. Here in the top, this is the normal response where the toes flex downward. And this is the general path that you want to take along the bottom of the foot when you're checking the Babinski. So you start laterally and you move up the foot and then move medially as you approach the toes. And if there is a Babinski sign present, the great toe will extend and the rest of the toes will fan out. And this is an important upper motor neuron sign. Next, we check sensation. So usually for light touch, we use a cotton swab. We compare side to side, and you also want to test distal to proximal as well as dermatome distributions. And you want to do this for also for a pinprick. We usually use a safety pin, and you again compare side to side, distal, proximal, and dermatome distributions. You can also use temperature, things like an ice cube or a cold tuning fork to help test for the spinothalamic tract function. Next is vibration, so we usually use a tuning fork, and this is also very important to test, especially proximal and distal, because patients with neuropathies frequently lose vibration sense. And then we also test proprioception, where you lift either distal phalanx of the toe or the finger, and you ask the patient to tell you whether the toe is up or down. Now, if they are unable to feel, let's say, at the toe, then you want to move more proximally and test at the ankle and see if it's present at the ankle. And if it's not present at the ankle, that will tell you that there's even more involvement, and then you could move to the next joint up, which would be the knee. The next part of the neuro exam is the coordination testing. So usually we do finger, nose, finger. This is testing for dysmetria. It's really important to make sure the patient extends their arm all the way, because that really will help bring out any signs of dysmetria. If their arms are not extended, you may miss subtle findings. And then you do things like finger follow, where the patient keeps their finger close to you but not touching your finger, and then you quickly move from one side to another and the patient should follow you. You want to check for overcorrection. Basically, their finger would move either too far and then have to correct, or too little and have to move forward again. Then you test things like rapid alternating movements. You have the patient flip hand palm side, then dorsal side quickly and repeatedly, and this is for dystatogokinesia. And then you also want to check the other shin, which have the patient slide the heel down the other leg shin, and looking for any signs of discoordination or dysmetria. Next, we check his gait. So usually what we first test is stance, so just have the patient stand up, observe, are they leaning forward, are they wide-based? Leaning forward is often a suggestion of Parkinson's disease or Parkinson's-like syndromes, and if they're wide-based, it's usually a sign of ataxia. And then you check things like gait, and usually what I do is when I'm bringing the patient back into the office or assessing them, I like to observe their gait then, because it tends to be more natural than having them do it as part of a formal exam. But really what you want to look for are things like a shuffling gait, decreased arm swing, and block turning, which are all signs of Parkinsonism. Then you also want to look for wide-based gait or ataxia, which is findings of either cerebellar dysfunction or it could also be sensory ataxia syndromes. But these are also things to note. And then more difficult things are things like tandem gait, one foot in front of the other. And then heel walking and toe walking is helpful to look for subtle signs of weakness, either with the heel walking to look for subtle signs of weakness in the dorsiflexors, and toe walking to look for subtle signs of weakness in the plantar flexors. And that's it for the neurological exam, a brief introduction, but we will go through each section a little bit more detail in videos to follow.